Hello, welcome. We're pleased to welcome this great panel to discuss an issue that is really of vital importance in communities across this country, and that's the opioid crisis. Our moderator, John Temple, has written about one aspect of this epidemic in his book, American Pain, which is for sale in the hallway, and I highly recommend it. I told him that my wife and I read the book and decided that we would draft him for this role today, so we're pleased that he's here. And you'll hear about all our other guests in a minute. Let me just say a word about upcoming events. Next Monday, I'll be sitting down for a conversation with former White House Chief of Staff Dennis McDonough, and later that evening we'll welcome former U.S. Navy Secretary and former Governor of Mississippi, Ray Mabus. On Wednesday, April 25th, Laura Rosenberger and Jamie Fry of the Alliance for Securing Democracy will be talking with Kim Dozier about the Russian government's efforts to undermine public faith in democracy. And you can find out about this and all of our upcoming events on our website at politics.uchicago.edu. As always, we'll open the floor for audience questions. There'll be a microphone in the center aisle. As usual, we'll give priority to the first three questions to our students, and I'll make the also customary request that questions end with a question mark. Please silence your phones. The restrooms are on the first floor. And now here to formally introduce our speakers is Joseph Donahue. Joseph is a second year from Ann Arbor, Michigan. He's studying economics and French. He has served as both an events ambassador and a fellows ambassador at the IOP. And this year, he has participated in our Bridging the Divide program, which partnered with Eureka College in Central Illinois to study the opioid epidemic and other issues in our respective communities. Please join me in welcoming Joseph to the podium.
Hi, everyone. Welcome to the IOP. The misuse of opioids is one of the most pressing medical issues in America today. Drug overdoses are on the rise, and it's the main cause of death for Americans under 50. Today, we're fortunate to welcome this panel to discuss how we got here and where we go from here. Our first panelist is Timothy Sini, the current district attorney for Suffolk County, New York, and the former Suffolk County Police Commissioner. During his time in public service, Mr. Sini has worked to increase access to naloxone, increase the amount of drug dealers who've been arrested, and he has also increased the amount of outreach programs for those suffering from drug addiction. Patrice Harris is a member of the American Medical Association and the chair of their opioid task force. As the director of health services for Fulton County, Georgia, Dr. Harris looked to integrate public health, mental health services, and behavioral health. Also joining the panel is Rahul Gupta, the commissioner for West Virginia's Bureau of Public Health. As part of his role, he's looking to use overdose data to reduce the likelihood of future deaths, and has also expanded naloxone distribution statewide. Our final panelist is Kelly Chenoweth. Ms. Chenoweth is in long-term recovery, meaning that she hasn't touched an opioid for over 13 years. She's now an active volunteer at the Hazelden Betty Ford Foundation here in Chicago. John Temple, professor in the Reed College of Media at West Virginia University, will be moderating this discussion. He's the author of American Pain, a book about the largest drug mill to ever hit America. Please give our guests a warm welcome. Thank you.
So I'm excited to be here tonight, and I wanted to say I was speaking with everyone in the panel a little while ago, and we realized that 4 of us have connections, either went to school or lived in West Virginia or currently live in West Virginia, as I do and Dr. Gupta does. I don't know what Tim Sini's connection to West Virginia is, but I'm assuming you have one. No, okay. Sorry, I'm not going to ask you any questions. West Virginia is kind of the episode, or one of the ground zeros. I don't know if there can be more than one ground zero, but of this epidemic. It's got the highest overdose death rate in the country. So maybe that's no coincidence that several of us are from there. I want to tell you, just to start, before I start asking questions and then we open it up to everyone, I wanted to tell you about this court case that is happening in federal court in Cleveland that has the potential to really shape this thing. Here's what's happening. There are hundreds and hundreds of municipalities, counties, and even some states have filed lawsuits against drug wholesalers, against drug manufacturers, and even against pharmacy chains. And instead of litigating each one of these cases separately, they did what they called multi-district litigation, MDL. They bundled them all together, and they put them in one judge's lap in Cleveland, Ohio. People are sort of comparing it to the big tobacco settlement of the late 90s, which was $250 billion settlement to be paid out over several decades. This could be bigger than that. So this could be a lot of money coming back to those plaintiffs. There are like 12 defendants in the case and more than 400 plaintiffs, different municipalities, like I said, and counties. So, I was talking to the lead counsel of one of the largest wholesalers, actually one of the biggest companies in the world, a while back, and he said that he expects to be dealing with these cases for the rest of his career. It's not, this is just his life from now on. We'll be litigating and defending his this wholesaler against. So this is just going to be an ongoing thing. But there is this one thing that's happening in Cleveland that is going to be a very big deal, and it could be $500 billion type settlement. So. One caveat, I was speaking to one of the major plaintiffs last week, and he said that he is not sure that this case is Big Tobacco 2.0. This is a more complex case because of the nature of what's happening here. The tobacco, there is no medicinal value to tobacco, whereas the challenge of the opioid epidemic has always been that this is a legal drug. This is a drug that is very useful to people, and these are a set of drugs that are very useful to people. So, how do you regulate that without just choking off the supply, which would be very bad? So, all that said, a little bit of background. There may be a really large settlement going back to these counties. So the questions I wanted to pose today were I wanted to sort of frame this in that context, that there may be a lot of money that we can use to attack different parts of this problem. So I want to ask each person on the panel, what are we not doing yet? What opportunities are there out there that we could approach, that we could attack? Particularly if we get a big influx of money. So I wanted to start with Dr. Gupta. Can you just tell us a little bit about the social autopsy program and what the takeaways are from
Sure.
that? Yeah.
Thank you, John. And again, thank you for the Institute for inviting us and my co-panelists here today. As you all know already, that West Virginia is at the hub, basically, of the challenge. It's tough, actually, seeing year after year this number of people die, and which is often the tip of the iceberg. But at the same time, It touches every fabric of your society, everywhere from the babies that are born with neonatal abstinence syndrome, to child welfare spend, to social sort of programs that where spending is increasing literally logarithmically. The criminal justice system burdens, as well as others. So one of the things we wanted to do was we wanted to start out looking at this. When we say chronic brain disease relapsing, we often stop there. So if you compare that to like heart disease, if you're a 50-year-old male goes into your doctor's office with high cholesterol, they're going to know, yes, they're going to put a sort of tag on you. You'll be a high risk for heart disease. We do not really have those measures. So what we did in West Virginia last fall, being tired of seeing so many deaths happen each year and really didn't have a pro forma from anyone else, we actually went back and looked at every death in 2016 that had happened and conducted like a CSI interview. We conducted a social autopsy. We wanted to not just know the medical cause of death, what's on the death certificate. We wanted to know their incarceration status. We wanted to know who these people were. What was their education status? What were their marital status? Where were they living? Did they vote or not? Were they registered to vote? So all of the aspects to actually go back and make that person alive again. And we found some very compelling things. We found that 9 out of 10 people that died actually had a history of prescription-controlled substance. In fact, 49% of the females had filled a controlled substance within 30 days of their death. We also found that all of these folks had actually come into contact with the healthcare system, 4 out of 5. So it's not like these people are on the streets and they don't touch the system. We seem to have missed those opportunities. We also found that 56% of these folks had a history of being ever incarcerated. And within 30 days of being released, you have a very high risk of dying because of overdose death. So when we found numbers like these, we actually then put a panel together, brought in folks, national experts, and did some recommendations to reduce the number of deaths. Obviously, they were very common things you would think about: expand treatment, medication-assisted treatment, expand naloxone, reduce stigma. Then we converted that, and I'm talking about only in the last 6 months. West Virginia has a 60-day legislative session. So instead of talking about how to imprison these people, actually, we've sent the report up to the governor. He sponsored 2 sets of pieces of legislation, and it was just signed a couple of weeks ago. So now we're expanding MAT. We're providing exemptions for primary care docs who treat up to 30 patients from any regulatory barriers of the state. We've just purchased 30,000+ doses of naloxone with state money, $1 million to actually give. But more importantly, we've actually been mandated first responders to carry naloxone, provided they can afford to. Not just trained, but mandated them to carry that by law. So all of these provisions is an example, especially for students, is how you can actually have a data-driven policy making and not take 100 years to do it. So that's something that we've done, and I think one of the reasons we're starting to see some improvements, and very early to say, but we are seeing flattening, is just because of the information that's been shared amongst people across, because we did it in public sector sort of thing. We had hundreds of comments from people, everything from every comment we had to that we need treatment, we had a comment to lock them up kind of thing. So we have these comments, and we involve the public in developing that response plan, and we're very excited to see the future happen, the best chance we've had so far because of that.
Great, thank you. You mentioned medication-assisted treatment. Kelly, can you tell us a little bit about your story and also your experience with Suboxone?
Sure. Hi, everyone. I, like so many others in recovery, started with a different drug, and that drug for me was alcohol. I was a social drinker who became a nightly drinker, who became a daily drinker, to the point where I became a problem drinker with consequences, and I needed to stop. So I did. But unfortunately, I stopped using the Kelly program, which means I had no idea what I was doing. I didn't ask for help. I just stopped drinking. And a few months later, again, unfortunately, my husband was diagnosed with cancer. So our focus quickly shifted from treating my disease, which we were barely doing, to treating his disease. And when he was diagnosed, I was in pretty bad shape. I had used alcohol to cope, so I basically had no coping mechanisms. I was afraid my husband was going to die. And I remember walking into his hospital room one day, and I saw a bottle of pills, a bottle of pain pills. And I thought, you know, I need something. I need relief. I don't want to feel these feelings that I'm feeling. And I took 2 of his pain pills, Dilaudid. And within a few minutes, I remember thinking, well, I don't have to worry about this drinking thing anymore because now I have pills. And I felt so good, in fact, that I thought, well, I'll just take these forever. But that feeling didn't last long, that feeling, that high feeling. It lasted about a month. And then I spent the next 4 years chasing the feeling, but then giving up and just taking them to feel normal. I really needed pills to get out of bed in the morning, to go to my job, to not feel drug sick, which happened on a daily basis. And drug sick is like, for those of you who don't know, it's kind of like the flu times 1,000. It's terrible. And what happened to me is I got sick and tired of being sick and tired. I don't know if you've ever heard anyone in recovery say that, but I have a lot of yets in my story. I haven't OD'd yet, and I haven't been arrested yet. But I really, truly was worn down by the chronic obsession that was going on in my brain every minute of the day except when I was sleeping. So I told my husband what was going on. Like, we think we're so sneaky, but he knew. And I detoxed for a couple of weeks, and then treatment at Hazelden Betty Ford here in Chicago was recommended. I went there, but again, I was in pretty bad shape. I was suffering from post-acute withdrawal symptoms. And for me, what that meant is I couldn't sit still. My leg was doing this all the time. The counselors were writing things on the blackboard. I literally could not read what they were writing. I was sleeping from 10 o'clock at night till midnight, bad shape. I saw an addiction specialist, an addiction MD, and she took one look at me and one look at my vitals and said, if we don't do something for you, I'm really afraid you're going to go back to drugs. So she recommended medication-assisted therapy, and this was in 2005. Suboxone, which was the drug that I was placed on at the time, was FDA approved in 2002, so it was still relatively new at the time. She put me on Suboxone on a Friday, and I remember, like it was yesterday, waking up on Saturday morning. I had slept. I was sitting in the living room of our home, drinking a cup of coffee, reading People magazine, and watching the Today Show, and I'm like, whoa, put the brakes on, what's going on? I have not felt this good in years. Suboxone medication-assisted therapy literally changed my life overnight. And it allowed me to go back to Hazelden on Monday and sit still and read and listen and talk and really be an active participant in my own recovery, and to really learn the tools of recovery and about working a 12-step program. What I did then is what I continue to do almost 13 years later. I work a 12-step program, and I'm on medication-assisted therapy, and that combination has been very effective for me. Thanks.
So in keeping with the sort of theme of, you know, what can we do better, is there, as a person who uses Suboxone, is there anything that you see that you just think, why did they do this? You know, what, this could be done so much better. It could, or anything like that come to mind?
Well, I've dealt with a lot of judgment over the past 13 years, to the point where I really only talk about the fact that I'm still on Suboxone to select people. What, you're taking a drug? Don't you get high from that? Which I haven't gotten high one single day from being on Suboxone, just FYI. People in the recovery community, some of them still don't quite understand Suboxone, and it really honestly bothers me when I read something. I read something where it's just not fairly balanced.
Yeah, that's really interesting here. Dr. Harris, can you, we're talking about medication-assisted therapy, we're talking about Suboxone. Can you kind of, define those a little bit, and then I'll ask you a follow-up question.
Sure.
But, yeah, we should have defined those at some point.
Sure. Well, first I want to thank Kelly for sharing her story. We thanked her in the green room, but there are so many lessons learned with her story. First of all, she had a treatment opportunity. And we know that there is very uneven access to medication-assisted treatment in this country. In the best states, 4 out of 10 clients who want medication-assisted therapy can get that therapy. And in the worst states, it's 1 out of 10. So we really have to do something about the lack of access to treatment. Medication-assisted treatment is evidence-based. It means we have the science behind it, and it is known to work. The best practice is the medication. Kelly was on Suboxone. There are 2 other medications, Vivitrol and Methadone. And importantly, she talked about the psychosocial supports that she received. For her, it was 12 steps. For others, it may be other interventions, but the key is the medication in combination with psychosocial supports that is best practice and is evidence-based. Kelly also shares the stigma that she received and still does, so much so that she does not share with everyone that she continues to take Suboxone. And that, again, is a reason to thank her for the story, because it's only through sharing those stories, hopefully, that folks will understand that is not a character flaw, first of all, having a substance use disorder, and then being on an evidence-based treatment is not a moral weakness. Certainly, medication-assisted treatment is not for everyone. It's not a one-size-fits-all approach here, but it does work. And she has been on it long-term. I have the opportunity to do media interviews, and I get a lot of questions because, again, there's a lot of misinformation out there, and there still is stigma for folks who continue to take the medication. And I always ask the question, if someone has diabetes or high blood pressure, they likely need to be on medications for a lifetime. And we should consider medication-assisted treatment in the same way. So many lessons learned through her story, but the evidence is clear that medication-assisted treatment is a very effective therapy for those who have opioid use disorder.
Thank you. Mr. Cini, you have been a prosecutor, you have been police commissioner, and now you're district attorney of Suffolk County. you have a number of programs in the works, and I'm curious what you would do. I don't know if Suffolk County is part of the MDL in Cleveland or not, but if you did receive a big settlement and had some money, some resources to use in this, where would you allocate it? Where would you go with it?
So we have state litigation that we are a party to, okay. And we actually were selected as the host county to litigate the action. So all the counties who are involved in the New York State action against the pharmaceutical companies, that action has been consolidated in Suffolk County. So we're very proud of that, and obviously we don't know what the outcome of that litigation will be, but certainly any settlement or award that comes from that could be put to a lot of great use. The fact of the matter is there's no silver bullet. We need to be investing in prevention, treatment, recovery, law enforcement, everything. But as a law enforcement official, what we need to do is continue to develop consensus that addiction is a disease, and we need to treat it accordingly. So you often hear law enforcement agencies talk about how data rich they are. We have an enormous amount of data, and as we increase our ability to collect and warehouse and analyze data, the potential of using that data really become amazing. And oftentimes you hear law enforcement agencies talking about using data to target criminals and arrest individuals. Law enforcement agencies need to use data to find people who need assistance and be part of that intervention and help people get into treatment. So the way I view my role is that there is essentially a spectrum of opportunities for intervention that law enforcement can be involved in, whether it's pre-arrest, at arrest, post-arrest, pre-arraignment, post-arraignment, and even in jail and when you're released from jail. So what I'd want to do is utilize any potential funding to fund programs at every step of that spectrum of opportunities for intervention. So we launched a pre-arrest pilot program. I use asset forfeiture money. Asset forfeiture money is money that I seize from criminals pursuant to due process, pursuant to a state statute. And I received an opinion from my state comptroller that I could use that money not just to fund crime-fighting initiatives, which is traditionally what it's been used for, but also crime prevention. And I made the argument that that includes drug prevention and treatment. And so we use that money to fund a program where we use our data, whether it's overdose data, people utilizing pawn shops, arrest data, all sorts of different type of data to essentially identify individuals who are likely suffering from substance use disorder, and then refer those individuals to OASIS License, which is my state agency that licenses treatment facilities, OASIS Licensed Treatment Facilities. And we utilize an organization that specializes and is essentially the professionals in coaching folks into treatment. And then we have strategic partnerships with treatment facilities that will guarantee treatment beds for any individuals referred by law enforcement. So that's an example of a pre-arrest program. We're trying to reach out beforehand. We're also about to launch a new program that's at arrest, where essentially if you are arrested for a drug-related offense and you meet certain criteria, we essentially pitch you an opportunity to have your case dismissed. In fact, never even prosecuted, actually. It's sort of held in abeyance. And we bring in peer coaches and recovery coaches, and they explain the program to the person, and they essentially attempt to coach that person into treatment. And if the professional essentially certifies that the individual meaningfully engages in treatment, we'll dismiss the case. So we're incentivizing folks to accept treatment. We've also launched a pilot program in our jail utilizing medically assisted treatment. We screen all of our inmates, and anyone who wants can watch an informational video about medically assisted treatment that was put together by medical professionals, not law enforcement officials. And they talk about Suboxone, they talk about Vivitrol, they talk about methadone. And we actually offer a Vivitrol program in the jail. We will screen folks. We'll even give you a shot before you re-enter the community. So we'll give you one shot in jail, which for those of you who don't know, Vivitrol is an opioid antagonist. It blocks the opioid receptors and prevents you from getting high essentially for for 30 days. And in connection with the therapy, the 12-step program, it could be very beneficial because it gives folks that mental stability and clarity to stay in treatment. So we'll send people into the community with the Vivitrol shot. We'll connect them to a community treatment provider on the outside, and we'll do our best to keep tabs on an individual. So we need to create programs at every point that law enforcement is interacting with folks suffering from substance use disorder. We need to create programs that incentivize and facilitate treatment. And that, in the end, not only will be effective, I don't think I need to forcefully argue that jailing folks suffering from addiction doesn't work. If I need to make that argument, I will. But it doesn't work. The evidence shows that it doesn't work. Folks who receive treatment are 80% less likely to repeat crimes in the future. But it's also cheaper because jailing our residents, our citizens, is very expensive and usually ineffectual.
Yeah, I think Dr. Gupta kind of mentioned this, but people coming out of jail or prison are particularly vulnerable at that moment. So that's interesting about the shot. Do you have a sense of what percentage of them actually take you up on that offer? Or
so we've had varying success with the different programs I mentioned. For example, on the pre-arrest program, where we are reaching out to folks, and essentially the recovery coach is calling someone and saying, we've received your information from the Suffolk County Police Department or the Suffolk County DA. We know you need help. We're here to help you. That actually has been very successful. So we've actually been able to make contact with well over 85%. I think it's closer to 90% of the individuals. And 10%, and that number may not sound too impressive, but I think the medical professionals will vouch, 10% of the individuals that we've contacted have actually enrolled in an OASIS licensed treatment programs because of the contact. The Vivitrol program, less success. What happens typically is that the majority, meaning over 50%, somewhere between 50 and 60% of folks who we screen and watch the video will actually enroll in the program, receive the shot, and then the majority of those individuals end up not continuing with the Vivitrol shots on the outside, and we either lose contact with them or they relapse.
Right. Just to clarify what I said a minute ago about that people are vulnerable when they're getting out of prison or jail. They're not just vulnerable to going back to drug use, but when they go back, they've been clean for a while, presumably, and they're very vulnerable to overdoses at that point because their bodies are not conditioned to them.
Yeah, we have a high rate of overdose with respect to our releasees, and it's exactly for the reason you mentioned. Most people, despite what perhaps the movies show, most people are clean in jail. They get out, and when they reuse, they often forget their tolerance levels, and I'm sure the medical folks can explain it better than me, but we see a high rate of overdose in that population.
Right.
And I would imagine that a couple of issues are coverage. You know, we know that these treatments are not inexpensive. And again, Kelly had coverage, but we have to make sure that everyone has coverage. And then for those who have coverage, we have to make sure that parity laws are enforced. And I also know another barrier to some folks getting treatment was prior authorization from payers. But the New York Attorney General a settlement with some of the insurers to remove prior authorization requirements for those who have coverage. Right. To get medication-assisted treatment. But and you may not know this, and that's okay, but I want to raise that to the audience that once you leave jail, if you don't have insurance coverage, it'd be very difficult to perhaps afford the medication and the other psychosocial supports.
That's right.
If there's not a safety net system. That's
absolutely the case. So the pilot program that we have, it's funded by the government. So the drugs are provided. Essentially, they're donated by the pharmaceutical company, which is a company called Alkermes, and the treatment on the outside. What we'll do is we'll have folks from our Department of Health work with the inmate while they're in jail to get their insurance reinstated or get their Medicaid. Typically, it's Medicaid, get their Medicaid reinstated, and we essentially we'll get them with a navigator that our governor in New York State has helped fund a lot of these navigators to help these folks through the process. But there are obviously huge gaps.
Yeah, I'm wondering, you know, just being from West Virginia, you know, if you came to West Virginia and sort of pitched this to law enforcement in West Virginia, would they say, laugh you out of the room in the sense of saying, like, we just don't have those kinds of resources? Or have you had any experience like that? Because
the interesting thing about my population, when I say my population, essentially other than the pre-arrest, those are folks who aren't in the system.
Yeah.
But after that, it's essentially people who are criminally justice involved. It's not a huge population, so it really is the collaboration between the medical profession and law enforcement is critical, because it really can be the stage for laboratories of experiments with different type of programs. You know, the way we pitch, the way we try to coach people into treatment, and the different models that we use, because it's a manageable population in terms of size. And oftentimes these folks are under some type of court-ordered supervision, and there are extra incentives for these people to go into treatment. But I think even beyond costs, because again, the alternative is much more expensive. Jails are more expensive. I think it's beyond cost, and I can't speak for West Virginia, but I know that there are just some communities where they still are working on that paradigm shift. You have to treat this as a public health issue, and you also have to be nuanced. Obviously, the heroin trafficker who is making millions of dollars in profits, that's a different story, and you have to be strategic in the way you talk about these issues with the community. We were talking a little bit about harm reduction. So part of what I do in Suffolk County is harm reduction. We hand out fentanyl strips. We talk about safe needle use. We do needle exchanges, and you know, a lot of this takes people. It takes people who really have suffered from addiction and folks who have seen it firsthand to help you pitch these programs to the communities and shift that paradigm.
I also think that, just to add that the way in West Virginia, I'm very surprised but also thrilled to see our correctional people look at this, and they say to me, you know, 33.5 incarcerated individuals equals $1 million a year. 37 correction officers means $1 million a year. So they're making that calculations, and because of that, they've seen that it takes $20 million to run a prison. And they're actually working right now with us to turn one of those prisons into a treatment center. So these are the kind of things. I think money does go a long way, but I'll also alert you sometimes that be careful about the data and the way it's spun, because in our study we found 71% of decedents were Medicaid recipients. Now, West Virginia is a Medicaid expansion state where adult coverage rate is about 94% across the state. But you know, the first call we got was actually from the United States Senator from Wisconsin. And he said, there you go, that's the cause and effect. That means Medicaid people get drug addicted, right? So let's take the Medicaid away. Really, this happened. And we had to send an explanation of, no, you can't actually do that. That's the wrong spin of the number. So be careful. You know, we always struggle with not only finding data, but actually making sure it's set in the right context, because people will take it and spin it in a way that it makes it look like maybe the right things are not happening.
I mean, there's a whole host of reasons why this epidemic took root in West Virginia kind of earlier, but I'm curious, what, as a result, what do we know about this epidemic in West Virginia that maybe other places are sort of like only catching on to now? Any thoughts there? Or?
Yeah, so one of the most common questions I get asked is, why West Virginia? Most common. And my answer usually used to be, guys, have you seen the election in 2016? Seriously, that's the way I used to answer it. But I think we have
it's all Donald Trump's fault?
Well, second highest percentage of vote in the country, next to Wyoming, actually. So, but the point, what I'm making, the larger point is this. I think we are in this country very good if somebody gets into an accident in taking that person and resuscitating. We're actually also very bad at managing, once we save that person, their diabetes, their high blood pressure, and preventing strokes. Same way, put it here. if we were to get a $500 billion, I think we're very good in purchasing naloxone, expanding MAT. What we're not good at is, so while we're whack-a-moling, it was prescription drugs, then heroin, then fentanyl, then carfentanil, now meth. We continue to whack-a-mole. What we're not good at is actually looking at structural systems in our country. So social determinants of health. Where people live, communities, how to rebuild and reintegrate those communities. How, like, actually, are we really going to treat this for 10 million people or so as a patient and a physician problem? Or are we going to treat this as a community problem? The adverse childhood experiences and the trauma-informed communities, trauma-informed schools. So there is a longer-term way that we have to look at this. And you know, a former president did say we can walk and chew gum. So, but the problem is, we can't seem to do that. It's with this problem, it's with a lot of problems. We look at what's easy to do sometimes, but we also have to see, so we're not 10 years from now and 20 years from now still addressing the same problems, because economic development is a big problem. I go back to West Virginia, we lost the mining industry and coal industry and manufacturing and all that. And that's caused a lot of people that were very laborious, tough jobs. They lost hope, got addicted. We had 780 million pills shipped to the state in a matter of years, opioids. So we have to move that needle also, is the economics, education, all of the other social determinants of health, if we're not going to continue to sort of whack-a-mole the problem.
Yeah, I think that's really interesting. To sort of flip around what he's saying and approach it from a different standpoint, from your experience working with a lot of people and you know, knowing people in the recovery community, is there anything that any characteristics or personal history or habits or life circumstances that you see more common among successful recovering addicts than, you know, people who wind up, you know, what tends to make someone successful, or is it just a crapshoot?
Well, when I started treatment at Hazelden, they would bring in volunteers a couple of times a week. And these volunteers, they had 1 or 5 or 10 more years of recovery time. They looked nice, they were smiling, they were working, taking care of their kids, pretty happy people. And when I interacted with them, I remember thinking, I want what they have. And I've been volunteering at Hazelden for about 12 years, and that's what I hope that I can give back to the people there, that they can look at me. There's nothing special about me. I like to think I'm special, but there's nothing special about me. And if I can do it, then they can do it too. It's called hope. And I think having the support, you were talking about the recovery community, that's been part of the reason why I'm here today, is from day one, I had the support of Hazelden, and then I had the support of friends in the recovery community who spoke my language. You know, like my husband had cancer. I'll never be able to get cancer like he did. But people in recovery, we speak the same lingo. And so that fellowship, that friendship, that's really meant a lot to me. I hope that answers your question.
Yeah,
but.
Thank you. So I think we're going to turn it over to the students and others who want to ask questions. So I think we're asking you all to to take the mic up here.
Hi. Hello, can you hear me?
Yes.
Hi, good afternoon, or good evening, rather. I want to thank you all very, very much for coming here to share your stories and your perspective, especially your very, very special story, Kelly. Thank you so much for that. My name is James Lott, and I'm a student at the Harris School of Public Policy. I'm also a pharmacist, and I have a startup called FidgetScript. What we're doing is we're trying to bring medication-assisted treatment online for patients. So it kind of knocks out the barriers of stigma, and if you happen to be in a rural area, and we plan on extending services. We're also semifinalists in the Booth School of Business Social New Venture Challenge. My question is, I've been working in this space trying to come up with solutions for about 2 years. The space as a private for-profit company is intensely brutal. I'm wondering, tonight the theme I've gotten was, it's a public health issue, therefore public officials need to bring up the solutions. Outside of the pharmaceutical companies that make the drugs, what is being done to foster innovation, structural innovation, and otherwise for private companies to come into this space and build some public-private partnerships that would, where creative people can come and help bring sustainable solutions? Thank you.
I think there was some funding allocated in the latest budget proposal for research into alternative medicine, which I think is certainly a good thing. I think you raise an excellent point, and I'll turn it over to my fellow panelists in a moment, because I think you're talking about something a little bit different, right? You're not talking about alternative medicine, and of course we all know the pharmaceutical companies are now making billions of dollars off the epidemic because they're putting out abuse-deterrent opioids, and you're certainly not talking about that. So I think you raise an excellent point, and that is something that I think public officials should be thinking about, and it's something that I'll certainly bring back to my state, not just money for research and alternative medicine, but money for research and development of innovation to find long-term sustainable solutions.
So if you live in Europe, for example, and you get overdosed and you go to ER and then you want MAT, they're going to look at you like crazy, like, what's wrong with you? Like, why didn't you just go to your primary care doctor and get MAT? In the United States, it's relatively heavily regulated. It's regulated from federal level, regulated at state level. So what's happening, to partly answer the other side of your question, is you have to have a special, it's called Data 2000 waiver, training, to be able to prescribe these 3 FDA-approved medications. Then when you get down to it, you can't prescribe more than so many patients in your practice. Then you have to sort of be subject to various state laws that vary state to state from a regulatory standpoint. So there's all these complexities, good or bad. I'll leave that up to you to think about. But we are very different in this country, the way we regulate treatment for this particular disorder, and we almost make it special. And then you could think about the stigma that goes along, as opposed to other parts of the world.
Hi, my name is Anya. I graduated last year from the college with a degree in economics. I'm a full-time researcher, part-time student now. I had a question based on what Dr. Gupta said at the very beginning about expanding naloxone access. You mentioned like $1 million more for that treatment, for that drug. I wanted to ask about your reactions to a study that Jennifer Doliak released last month about the effects of expanding naloxone. For those of you who are not familiar with it, so she found that expanding access to this drug, which reverses opioid overdoses, actually increases opioid mortality. So I'm going to read from her abstract, just to quote her. She finds that naloxone access may unintentionally increase opioid abuse through 2 channels. reducing the risk of death per use, thereby making riskier opioid use more appealing, and saving the lives of active drug users who survive to continue abusing opioids. She found that the most detrimental effects are in the Midwest, including a 14% increase in opioid-related mortality in that region after expanding access to naloxone. So I wanted to ask about your reactions to this, because we obviously want to save the lives of people who are overdosing, and this allows us to do that. But on the other hand, it creates a moral hazard where people are now like, okay, well, I can abuse heavier opioids, I can abuse more because I know that there's going to be access to this drug. So I'm wondering what your thoughts on that are.
I'll be real quick. There's a long discussion behind it, but this seems to be, there's two sets of thoughts. One is that enabling mindset. And there's a lot of people who think about that. Why are we enabling people in so many different terms, whether it's syringe exchange programs, harm reduction strategies, or naloxone, and a number of other things. My argument always is, you can't treat a dead body, unfortunately. You know, so when people, you can't treat those people. So the chance of treatment only begins when you can help somebody survive. And yes, it causes a lot of issues for even first responders when they have to give somebody naloxone 3 times in the same day or 4 times in 2 days. And it does create societal issues in some. And that's the reason to have policies that cause not just administration of naloxone. What we have done is we've received 1115 Medicaid waiver. That's like a technical term for getting federal government's permission. But what we're now doing is, not only are we giving naloxone to people, but we're also allowing billing for warm handoff. So you actually get paid as a first responder to give naloxone to somebody on the street, and then if you can help them get into help, then you also get paid again. So we're actually creating incentives to not just save that life, but provide every opportunity for that life to enter into treatment without forcing that person, because again, not everybody's ready. But if you look at the stigma why people don't get treatment, only 40% in the SAMHSA study that you've seen, 40% want to continue to use the drug. 60%, millions of Americans, actually say that they have problem that they don't think that their employer will allow them or to be a MAT. They have a societal issue, they have an access issue, they have an insurance issue. So the challenge always is that there's a lot more when people don't want to get into treatment. There's a big stigma factor behind that. It's just not that they don't want to. Go beneath the surface. There's a lot of reasons that they really don't want to. But at the end of the day, I think every life is worth saving.
So I just have to respond, and I was going to make that very point. I just wrote an op-ed. Naloxone is not a moral hazard, and you just took the words out of my mouth. Every life is worth saving, and you also made a very critical point that naloxone is necessary but not sufficient. And beyond that goes the treatment opportunity, and beyond that goes making sure that there is support to address the social determinants of health. So I have to state that very strongly.
And just to piggyback, in addition to doing the warm handoffs after naloxone saves, there's also a whole conversation around the training and the distribution of naloxone. There's an enormous amount of education that gets pushed out into the community surrounding naloxone programs, at least where I am.
Hi, thank you all for being here. My name is Nancy Tan. I'm also a student at the Harris Public Policy School. I was wondering if any or all of you could expound on the complexities of the implementation. So especially as you've done this data research now, and you're putting together these fully comprehensive programs that consider every aspect of the stage. Are you collaborating with other counties, other cities, and how scalable is that? And then also, how fast are you churning through this works, this doesn't, and then changing course as needed?
Well, certainly, some of our programs are in collaboration with other jurisdictions. Unfortunately, I serve in a county. It's a large county, 911 square miles, 1.5 million people, but nonetheless, we have about 300 different forms of government. We have local village, town, state, federal. We have 29 law enforcement agencies. So that is actually an impediment to progress oftentimes. So collaboration is always the goal, but it's certainly hard to implement. In terms of looking at the data, I still consider ourselves in the beginning phases of many of the pilot programs. We have the pilot program that I mentioned, where we're reaching out to folks on our own based on data. That's very new. That started in October of 2017. The Vivitrol program started in about 2015, so that's been going on for several years. And then we have several other programs that are basically 2015, 2016. And we're doing it in small areas. It's not county-wide. We do different programs in different areas. And we put a lot of resources and energy into managing the data and essentially assessing the efficacy. And what we've done is we've secured money from HIDA, High Intensity Drug Trafficking Area. It's essentially a federal program that gives out money to jurisdictions and encourages collaboration. So we've basically funded, instead of taking money and say putting more police on the street, we've taken money and we've hired analysts to help us pour through this data.
I was just going to say, similarly, partnerships are very key. Relationships, stakeholder partnerships are key. Working with several states to similar things. But we were fortunate to have Governor Justice put $10 million this session into these different pieces of programs, including some of the cool things we're doing. For example, we're putting one of the NAS you heard about today, the babies who are born dependent on drugs, no fault of theirs, going to withdrawal. We have the highest rate, 5%, 1 out of 20 babies in West Virginia. So, and it's a completely preventable disease condition. So one of the things we've done is we have like an exclusive women's prison. And we've actually put money in to go on a non-coercive basis, offer those women long-acting reversible contraceptives. So that's those sort of things that we want to offer them in jails, which is much more transient population as well. So offer those so that people have a chance, women have a chance, as men too, to actually get into treatment, recovery, and then plan a family, rather than having very worried about the next generation. Because it's not just those and their parents today, it's the next generation 10, 20, 15 years from now we're going to see the consequence of this epidemic today. So.
If I could just add quickly about data, because you see two panelists up here that are talking about data-driven policies. Unfortunately, that is the exception and not the rule. And so as you all are working on this or learning about this or working in your local community, you should insist that policies are data-driven. You've also heard both of these gentlemen talking about inspecting what they expect. Unfortunately, that's also the exception and not the rule. So in our appropriate zeal to address this issue, we threw a lot of things out there, and now it's critical to go back. If possible, we won't always be able to tease out what worked at this point, because we threw a lot of things you know, at the problem in the beginning. But as best we can, it's important to go back and, again, inspect what we expect. I also want to talk about the solutions. I believe that nationally and even on the statewide level, we can talk about a framework for solutions. But I believe the best solutions to this problem are local public health, local law enforcement, local physician community, local peer support and recovery support experts working together. I was at a talk about some folks in Marin County, and I said, you know, what's going to work in Marin County is not going to work in my home county. I'm from West Virginia, so it's important that the local folks get together and develop solutions that are best for that local area.
Hi, my name is Aaron. I'm not affiliated with the university, but I'm glad the conversation kind of naturally shifted towards data-informed policy. That's the crux of my question. But first, before that, I just want to congratulate you on 13 years of sobriety. That's no mean feat, and one day at a time. But my question is this. I think, Dr. Gupta, you raised an excellent example of, you know, towards the end of data-driven policy, it's very likely that, you know, policymakers can conflate correlation versus causation, at least in that example. But now when you're getting down to the local county or district level, where suddenly we have the ability to, as you said, take massive collection, warehousing, and analytics capabilities to the forefront. How do you ensure that you're separating the signal from the noise in these large data sets where it could imply a number of potential solutions or policy directives? Do you employ, you mentioned you brought on some analysts, do you employ statisticians? Do you consult with medical experts on the implications of the data that you collect? What's the strategy, I guess?
So there's two different sets of data, right? There's the data that we're looking at that allows us to identify folks who are suffering from substance use disorder, or at least are likely suffering from substance use disorder. And then there are the data that we're collecting to essentially assess the efficacy of the different programs. On the former, we're not always identifying the right people, but we typically are, because we know what the indicators are through experience. So someone who is frequenting a pawn shop daily is either some sort of collector or someone suffering from substance use disorder. But on sort of macro analysis, I think it's incredibly difficult to answer your question, because of the fact that we've done a lot, particularly with prevention too, right? So my average overdose, the average age of the person overdosing in my county is 30 to 35. The next largest group is 25 to 30. You don't really get down into 16 to 20 until it's like the fourth age range that pops. Does that mean prevention is working? Or is that consistent with historical trends throughout time? So there's a lot of stuff that we need to look at for sure. We're seeing right now a trend in 2018 of a reduction in overdoses. And I had a law enforcement official in my county tout that recently, and my hair went on fire, because 3 months of a reduction. We've had 5 years of insane increases, and we've had 3 months of a reduction. We have no idea what that even means. We do employ analysts, and we do employ folks to help us study the data. We use the Finn Institute. We use Stony Brook University, which is a state university in Suffolk County. We do partner with folks. We recently entered into a partnership with the Kennedy School of Government to help us develop processes to essentially conduct analytics.
I want to make sure we have time for the next two questions. We only have a few minutes left. So.
Hi, my name is Dylan. I'm a second year in the college. Dr. Harris, I'm wondering if you could talk about the AMA's Opioid Task Force and what some of the ideas coming out of that are. And then if any of you would be willing to comment on the President's Opioid Task Force and more broadly what the federal government has done and really should be doing in the future.
Thank you. So the AMA Board of Trustees established the Opioid Task Force in 2014 and appointed me as the chair. And the task force is composed of representatives from 26 either state or national specialty societies and the American Dental Association. And our initial charge was to first demonstrate physician leadership on this issue, amplify work that was already underway, and then identify ways that we could disseminate best practices to the physician community, as well as collaborate with partners in the community. And we came up with 6 recommendations. I know we're short of time, but you can go to our website and see our 6 recommendations. And we are charting our progress on those recommendations as well. And I'll be happy to stay after and talk to anybody more about the work of the task force.
And I think the President's Commission, to a lot of people's surprise in public health community especially, was quite nice. In fact, that if those recommendations are looked upon, they've really covered a lot of ground. So there's opportunity here to work off of that. I think one of the important things also to remember is the White House Council of Economic Affairs that came out with a $504 billion a year economic loss to the country. Not only is that happening in 2015 dollars each year, but then you also have that we are for the first time losing 20 to 25% of labor participation rates because of the opioids. So this is the largest, the biggest domestic policy issue we have to face today. Most people in my position will tell you that. Yet, I think the effort can be more because although that report is the first step, but it's only the first step. I think the funding is another step, but we've got to be able to do more because it is, again, a very big issue, and we're losing $500 billion and workforce. These are people, they're not 12 years old and they're not 70 years old. The majority of people are between 25 and 55 years old.
Hi, thank you so much for being here. My name is Angela. I'm also a second year in the college. My question was, what should the relationship look like between drug distributing companies and government regulators? And is there any room for collaboration between the two groups?
So, as I'm sure many of you know, there is a revolving door in regulation and private industry, and I submit that that's a problem. I know people whom I respect a great deal, but nonetheless, one day they're fighting to regulate the pharmaceutical company on behalf of the DEA or another organization, and the next day they're making $500,000 defending the pharmaceutical company, and that needs to change.
And I would add to that very quickly that there's a lot of efforts now by the pharmaceutical companies to distribute antidotes, kits, distribute other things. Again, there's the concept of there's no free lunch. We have to be very careful, very smart about it. So if there's a relationship, it has to be fully transparent and accountable. This is not like tobacco industry that every time, if I had a nickel for every time we get an offer to, I'd be rich. But so that's a different thing. And with the soda industry, for example, that's a different thing. This is another area. I hope we can get to a point where we really have non-opioid alternatives to pain. We may need a public-private sector relationship in research and development and that. But I think that the backbone of that has to be transparency and accountability.
Thank you.
Well, thank you all for coming. This has been really illuminating for me. Speaking of that last question about the connections between pharmaceutical companies and manufacturers and the government, there is that revolving door. But another issue I think at the DEA is that the DEA's got two jobs. One is to enforce the law, and arrest people who are, inappropriately distributing controlled substances, whether they're legal or illegal. But they also regulate, and the law. So they tell us how to use, or they tell pharmacists how to distribute drugs. They tell wholesalers and manufacturers how many of each controlled substance they're allowed to produce each year, and those two roles are kind of in conflict with each other, I think, and I've talked to a lot of people at the DEA who feel the same way, because on the one hand, you've got an agency that's supposed to control the flow of drugs, and on the other hand, they're arresting, and it seems like the arrest mentality, or the policing mentality, is what governs the DEA. So anyway, something to think about. But I think that it's really exciting to see all these young students with these questions, because this is going to be going on for your lifetime, and there are many careers to be had in trying to solve this, especially if like we said, that some of these lawsuits end up producing gigantic settlements. So thank you again for everyone, and to this great panel.